the didactic today is we're super excited to have our very own homegrown Brian Talbot Clark, who is our licensed clinical social worker for palliative care team, as our guest didactic speaker. We're sad to miss Allie, who's our other fabulous LCSW, but she is ill today. Send her good thoughts, please. Brian will be presenting on hospice care in Alaska. This is meant to be kind of an interactive presentation, so if you have questions, just save them until the end, and we will be able to maybe answer those. We'll try. So, take it away, Brian.
Thank you very much. My name is Brian Talbot Clark, and as you said, I'm a clinical social worker with the palliative care team. My background is largely in grief and hospice work. I worked most recently with the Providence Connections program, doing work with families who were getting ready to reach the point of hospice, and so we're sort of counseling them through the transition. And prior to that, I worked with Hospice of Anchorage for 7 years as executive director for 2 of them. So this is an issue that's near and dear to my heart. I got started actually in hospice, as many people do, through a personal experience with a family member, and got to see how the benefits of the interdisciplinary team approach and the support that gets wrapped around the family was able to allow our family to come together and focus on being present with each other rather than a lot of kind of the practical day-to-day concerns that can consume you when a family is coping with an illness. So looking at hospice care in Alaska, we wanted to think about how the benefits to the family and allowing the family to cope with illness and be present for each other as a family, how we bring those benefits to people around the state, not just in the larger communities where all the services are available. Thank you. But as you look at the elements that are included here wrapped around the patient and family, it addresses a lot of the kinds of issues that any family in any setting is likely to face. From the medical director providing expert medical advice on managing symptoms and managing medications, spiritual support, social workers who may be looking at counseling or may be looking at practical concerns of the family, working with benefits and so forth. Grief and bereavement, always an essential element, as hospice does not begin or end with the death of the patient. Home health aides providing personal care and assistance and training caregivers in tasks of caregiving. Therapists providing physical occupation speech therapy, focused on comfort rather than what you might find in a home health setting. Nurses providing assistance with skilled nursing tasks and day-to-day management of symptoms and distress, and volunteers who can provide some additional support to the family. So these are sort of elements that are wrapped around the family to help address all of the many different dimensions that we understand as being part of the suffering that a person may experience and their family as they approach end of life. So let's take a look first at the full service hospice, where all of these elements are actually wrapped into the agency that's providing the care. So as I'm sure most of you know, the hospice benefit is a benefit under Medicare. Coverage for hospice may also be provided by Medicaid or by private insurance. Most private insurances cover it. Medicaid will cover it when Medicare is not available. Medicare covers, the numbers vary year by year, but generally between 80 and 90% of the hospice care that's delivered in America. So they tend to write the rules, and Medicaid follows Medicare's guidelines. Private insurances tend to as well, just so that they don't have to reinvent the wheel. So the Medicare benefit, basically it takes the place of regular Part A benefits when someone is on hospice. It kind of takes over in place of hospital benefits. So the elements that are included in Medicare hospice, a lot of them are included by regulation. And so the required elements include a medical doctor who is oversees care from a medical standpoint. And any individual patient can choose to keep their own doctor, or if their own doctor is willing to stay on as attending. It's not required that the hospice medical director become the attending provider. Sometimes a person has a very close relationship with their own primary care provider, and they choose to stay engaged. That can be a considerable commitment because the hospice care is provided on a 24/7 basis. Nursing care and nurse case management is the element people are probably most familiar with. It's provided with a schedule of visits as well as having 24/7 support available by phone. That hospice phone number is intended basically to take the place of 911 for the family while they're on the service. Social work is a required included service for both for psychosocial support and for helping the family with practical needs. You know, something comes in the mail, you're having trouble with your renewal on your Medicaid or other benefits, trouble with housing, whatever it is, the social workers are there to help the family to address those concerns and not be left out in the cold. Home health aides are included. That sometimes is misunderstood by the family, then it has to be clarified that it's not PCA or PCS, it's not hours and hours of support, but they can come in to provide a certain amount of, a couple of visits perhaps a week, helping with, providing bed baths or other comfort related tasks, training family members in how to do some of those tasks as well. Sometimes people aren't aware that volunteers are actually a required element of Medicare Hospice. So as it says, that 5% of all direct care hours need to be provided by volunteers. And that can help to kind of create additional relationships. A lot of people at end of life may be very isolated. They may not have a lot of loved ones that are involved, or their loved ones may, still be working, and there may be a lot of a sense of isolation as they're coping with end of life. And hospice staff can be there on a limited basis, so sometimes getting them engaged with a volunteer who can come and sit with them and be able to provide a longer visit. That relationship can be incredibly valuable as people are confronting end of life. The hospice benefit includes any durable medical equipment that needs to be delivered to the home. That's all required to be included in the hospice benefit, from hospital beds, bedside commodes, all of those things. Supplies and care focusing on comfort, such as wound care, catheters, are included as well. Again, as long as the focus is on comfort. The hospice benefit covers all medications, and as people are coming onto the service, there's a process of reviewing the entire med list, and usually it gets cut way down. That can be a great quality of life improvement right there for the patient. That we're looking at reducing the number of medications to the minimum that are required to provide comfort and relief of symptoms. Anticipatory grief assessment as well as support for the families. So this is a very important element, that grief support begins at the time that people are admitted. And when that good grief support is there before the death, oftentimes we find that there's a lot less support that's needed after the patient passes. Support is also then provided on an ongoing basis to the family for at least a year after the death. And that's a really important element also, because we find with grief and bereavement that there's almost always an anniversary effect, and being present with the family members and at the level of engagement that they're comfortable with, that they direct us. Some people, all we would do with hospice is just send them mailings at certain intervals, letting them know, here are some resources that you may find useful. Grief doesn't follow a timetable, but here are some things that you may be reaching a point this many months after the loss where maybe other people are expecting you to be over it. And so here are some sort of supportive resources for where you may be. And then as we come to the anniversary, helping them prepare for what that may be like, and seeing where they are and seeing if they need referral for additional help for complicated grief or extreme grief reactions that are providing more of a hindrance to the family members. Medicare Hospice recognizes 4 levels of care. Routine care is what's generally provided on a day-to-day basis, and then the other levels of care are provided like respite and general inpatient are both levels of care that can be provided in the hospital setting. Respite to provide family members a little bit of a break that can be for up to 5 days when it's necessary. General inpatient, people can actually be admitted to the hospital while they're on hospice if it's for addressing an issue related to that's outside of their hospice diagnosis, or if it's felt that an extreme short-term intervention is really necessary to restore comfort. So then dietary counseling, therapists. PT, OT, and speech are not frequently very involved, but speech therapy, for example, may often be employed when the patient is losing the ability to communicate, and helping them to retain that ability to communicate as well as they can as a quality of life issue for as long as possible. So all of those services then are tied together in the form of the interdisciplinary team or interdisciplinary group. All of the different providers that are involved in patient care meet and review the plan of care on a regular basis, every 1 to 2 weeks, depending on the size of the agency, as at least every 15 days, to make sure that everybody's playing from the same sheet. Eligibility for Medicare Hospice, for the Medicare Hospice benefit, there must be a life-limiting illness or condition. You've probably heard it needs to be certified as 6-month terminal. And so there has to be a referring physician to write that certification of terminal illness, and then the hospice medical director will review the case. If they agree, then they'll go forward with the admission. The Medicare requirement is that 2 physicians have certified that the condition is terminal within 6 months, as it currently looks. That doesn't mean that people get kicked off the service after 6 months. It's just on an ongoing basis. It has to be reviewed and see if the patient is still in a position health-wise where ordinarily we would expect to see death within 6 months. There are specific disease and condition-related criteria, and this has been a challenge for Medicare Hospice from the beginning. That these criteria can sometimes seem to be moving targets. Prognostication is something that sometimes we're not as good at as we'd like to be. And when Medicare reviews, if they determine based on the record that it looks like a patient may not have been ready for hospice when they were admitted, that their clinical picture might not have justified that 6-month certification of terminal illness, even if they did in fact pass within 6 months, then Medicare will charge back retroactively any funds that were paid for that patient. So that's been one of the major challenges for Medicare Hospice, and one of the reasons why Medicare Hospice often gets invoked later in the process than might be most beneficial for the patient. So Medicare Hospice is paid on a per diem rate. They got a flat daily fee that covers everything that hospice covers, and so that makes it very challenging for a Medicare certified hospice to operate in light of the lateness that we tend to see in referrals. Because if people are only referred when they're very acute, then you don't have the less acute patients where you're spending less than that per diem rate to offset the more acute patients where you're spending more. So that's where the financial challenge comes in, and why it's difficult to offer Medicare Hospice in smaller markets. As I say, the benefit has to cover durable medical equipment, it has to cover medications, as well as the bereavement care, which is not billable after the patient's death, but is required to be provided for a year after death. And so these regulations provide some challenges, as I say, in being able to provide these services in any but the larger communities. Currently, there are 5 Medicare certified hospices in the entire state. There are 2 of them in Anchorage, 1 in Mat-Su, and then 1 each in Fairbanks and Juneau. So as far as what is and is not covered by the hospice benefit, there are a couple of gray areas that come up often. So treatment intended to cure illness or prolong life is not covered. Now this, as it says, can be a big gray area. And as far as the things that hospices don't provide, that can be a mix between things that are by regulation they're not allowed to offer versus things that are just not economically feasible for them to offer. And so there are things, so hospice, for example, is not going to be able to offer palliative chemotherapy. Patients who are end-stage renal who are on dialysis can receive hospice. They can be on a Medicare hospice benefit, but generally that's not going to, that would only happen if there were a terminal diagnosis that were unrelated to the end-stage renal, because you have sort of a catch-22 that if a person is on dialysis, as long as they remain on dialysis, then there may not be, you may not be able to say that the end-stage renal is going to be terminal within 6 months. And if you could, then it becomes more the economic matter of being able to offer dialysis under the hospice daily rate. So it's rare that you'll see someone who is still on dialysis receiving hospice services. There may also be issues like transfusions. Some people receive transfusions for comfort, but again, that's difficult to manage under the hospice daily rate. So we've had patients even recently where that was a barrier to admission, and there had to be negotiations about how frequently transfusions could be offered. Medications and treatments that are not related to the terminal illness are not covered by the hospice benefit. They can still be covered by Medicare Part B. They can still be covered by private insurance. Things that are related to a different diagnosis and unrelated to the terminal diagnosis, people can still get treatment for those. That sometimes is not clearly understood. And so again, durable medical equipment, other things that are not directly related to the plan of care. Room and board is not covered by hospice, and sometimes we have to remind people that hospice is not a place. In other states, there are hospice houses where people would actually go to receive hospice services. We don't have those. There have been conversations about putting hospice houses together, but that hasn't happened in this market. So it's provided where people live, which may be at their home, or it may be an assisted living facility that provides their room and board. But hospice would only be providing room and board if they're doing a short-term hospital stay or something like that. You may have noticed that the bulk of the presentation has been looking at what is and is not included in Medicare hospice to give an idea of the services that we tend to include. It's a much shorter presentation when you're looking at the services that are available outside of the larger communities, because that's a challenge. That is a continuum of care challenge that needs to continue to be looked at for the future. But in many of the smaller communities, and it is an ever-changing list, there are smaller volunteer hospices available. This is a model that is actually delineated under Alaska statute and regulation. There are rules that are set up for volunteer hospices in addition to full-service hospices. There are some excellent organizations out there. Hospice of Anchorage is an example of the volunteer hospice model. It's actually a little bit unusual because it does offer nursing. Most volunteer hospices do not. And in fact, the state rules don't define that as part of a volunteer hospice model. The Hospice of Anchorage has been grandfathered in for those services. But volunteer hospices do not bill for their services. They rely on grant funding, donations, other sources of funding. But they do have, because they are not bound to the Medicare rules, they have more flexibility on who they can accept, who they can help. And so a lot of the time they can help people that are more in that pre-hospice phase, where they have a terminal diagnosis that they're coping with. Life is already going crazy, but they don't meet the Medicare definition yet. So that can be valuable even in the larger communities where full-service hospice is available. The patients have to have their own physician. Sometimes, for some people, this is a selling point, that they want to keep their own doctors. And because it's not that 24/7 commitment, it's easier for them to keep their own doctors than it is to keep your own physician as attending under full-service Medicare hospice. But people stay under their own insurance, and so the hospice isn't providing medications or durable medical equipment. They would assist the patients and families in accessing community resources to provide those. So then when you move out beyond where the volunteer hospices are available, and you're looking at the smaller communities in Alaska. I'm sure that folks on this call could expand this list greatly, but just a few of the barriers that apply to providing end-of-life care in rural areas, in addition to simply not having the agencies available. It can be difficult to get hold of medication in a timely manner when it has to be shipped out, and you're limited by the formulary that's available in your local area. There may be limited access to durable medical equipment. There may be limited utilities available, and just the remoteness of the community, physical access may be an issue. So when we're trying to allow people either to remain at home in these smaller communities or to return home, there are a few things that we look at as far as partnerships with the community health aides, as far as reaching out to the providers out there. The thing we wanted to put first on the list, we wanted to give recognition to listening to and respecting local and cultural practices, understanding that some of these smaller communities, they've been dealing with death and have ways of dealing with death they've been doing for thousands of years, and have things that they can be teaching us as far as people being around death and understanding and doing the undertaking. And so the first thing to do is to understand that we may not necessarily know exactly what they see as the gaps at the areas where they're going to be looking for help. So approaching with humility and listening to the patient and family as to what really their needs are. And so looking at ways of integrating the community resources that are available, and let's say working through the community health aides, working through the nearer providers, working through the clinics and the regional hubs, and offering support and education through resources like the video teleconferences. And to be honest, it's a struggle. It's a struggle to make it possible for people to stay in their home communities and not have to follow the continuum of care, leading them away from home, through the hubs to Anchorage, allowing people to stay in the communities where they want to be. So there's a lot of opportunity, I think, for development moving forward. But that's all the lecturing at you that I have. Are there questions about the material we've covered?
This is Lois in Kotzebue, and I just have a couple of questions.
Please go ahead.
Okay. So one of the requirements for the hospice team is to have volunteers. Can family members be considered volunteers if they come in and help with the care of the patient? That's my first question. My second one is for the volunteer hospice programs you were talking about. Does Medicare consider that an either or? You can have one hospice but not the other, or can you have both simultaneously? Thank you.
Thank you. So as far as considering family members volunteers, the hospice agency is going to train family members in tasks of caregiving and support the family as best they can. I don't think they would be counted as volunteers. I think that would, like for purposes of the hospice counting their volunteer hours and their level of community support, I think that would be seen as kind of fluffing up their numbers, because the role of the hospice agency is to support the family. Unpaid family caregiving, if you reckon it even at minimum wage, is far and away the largest healthcare delivery system in the country. And there's no way that we can substitute for it, so our role really is to augment it. And then, I'm sorry, the second question.
Second question, can you double dip? Can you
double dip? There's no technical reason why you can't. It usually doesn't happen as a resource issue. Volunteer hospices have limited resources available because they can't bill for their services. Where I've seen that happen has been, for example, where someone is working with a volunteer hospice at a lower level of acuity, then they reach the point where they qualify for Medicare Hospice, but they have a relationship with a volunteer under the Volunteer Hospice Agency, and they continue that relationship as they go through onto the Medicare service.
Thank you very much.
Thank you.
Ron has a question.
When you talked about eligibility, and I have an answer for this, but I think it's helpful for everybody to think about, talking about shifting goals from this hope for a cure to a hope for a good death. And when some of our patients choose a resuscitation status that would have them return to the hospital, so they don't choose to be DNR, DNI, is that make them ineligible for hospice. In addition to that, sometimes there's a scenario where patients very much want to continue to see some of their specialists and not just their primary care doctor, but in addition, a cardiologist and other people if they had heart failure. Is there any reason they can't be on hospice if they're not DNR, DNI, and can they continue to see their specialty doctors?
Yeah, and in that case, I think you're looking at a situation where, as you imply, those conversations really need to happen, and the focus on goals of care really needs to be understood. If someone is going on hospice, it's with the understanding that when the next medical crisis hits, that they're not going to be going back to the hospital. In fact, in order to return to the hospital, they would have to deselect from hospice services. So the expectation definitely is that they would be DNR, DNI, or Comfort One, that they're expecting to die at home. So certainly those conversations need to happen. As far as seeing other specialists, if those are issues that are related to the terminal diagnosis, then any of those things would have to be billed under the hospice benefit. Okay. And the focus just really has to be on, is this about comfort and quality of life?
Great. I will clarify, hospices will take patients who aren't DNR, DNI in the hopes of having those conversations, and that they can slowly transition to that focus as they build trust in the communication. So it's not a non-starter. A hospital doesn't have to, we almost talk about it, we have to secure a DNR, DNI so that hospice will take them, as long as there's a feeling that that's what family really wants, but they're not ready to actually sign a document saying that right this second, given all the acute changes that have happened. A lot of hospices are willing to be patient as long as the patient qualifies and the goals seem to align well enough.
Okay, I see conference room 3 hand waving. Okay. Thumbs up. Thanks so much for playing with us. And thank you for Karen, who's struggling over there in conference room 3, because she was totally sideballed on this one, and it's totally not her fault. So as we move forward, if we could, we're going to turn it over to Dr. Tim Payne for introductions.